Welcome. My name is Dr. Gualamuz, and I'll be presenting on integrative public health. We're going to be talking about health policy fundamentals, reform opportunities, and challenges, all in the context of complex adaptive systems. Now, yes, it's a bit complicated, and we are going to be diving deep into specifics and details. And we're going to then also retrace and reflect from a broader or a more global and expanded perspective and scope. But we're going to be doing that strategically and be defining terms and concepts along the way so that it doesn't matter where you're coming in to the conversation from, you'll be able to catch up to. Now, the lecture or the video is intended as a resource to the audience for which I was invited to present to. However, I also wanted to make it public and share the insights to the broader audience and to the general public so that there can be an invitation and encouragement to engage in a more nuanced based conversation when we're talking about policy, when we're talking about mandates, public health, and everything that revolves around the US healthcare system. So let's dive right into it. Hold on tight and have fun. So let's start off by breaking down a little bit of my credentials and background, and I'll touch on it briefly, but I do want to go through it because it does relate to public health, and so it starts off the conversation immediately. Now, as I said, my name is Dr. Gualamuz, and we're going to start right at the top here. So I'm board certified by the NCCAOM, which is a national commission, meaning it's a regulatory board at the national level, and it certifies individuals who have done two things primarily. They've gone through a rigorous 4-year, 3,000 hours master's level degree program and have passed 4 board examinations. One that's biomedical, anything you can think of that is that would be a biomedical or allopathic or Western medicine medical exam, which would consist of A&P, which is the anatomy, physiology, pathophysiology, pharmacology, all the biochem, microbiology, and so on and so forth, as well as an acupuncture board exam, which would touch on the acupuncture anatomy, channel networks, needle technique, clean needle safety, contraindications, so on and so forth, as well as the herbal medicine board, which would consist of the contraindications for herbal medicine, the synergies that happen with herbs or herb interaction as we customize and formulate herbal concoctions or extracts. Excuse me. And then we also have a foundations exam, which consists of all the theories or all the theoretics of the of each of the subjects, so acupuncture, herbal medicine, integrative therapies, and what they emerge from. So what I do want to elaborate on here is that there's a broad spectrum in terms of who practices acupuncture at the moment in the US. So it varies from state to state because of the regulatory boards. Some states don't have regulatory boards. Some states have regulatory boards that we can maybe even say overregulate. Now, in the state of Florida, I'm licensed in the state of Florida, by the way, as an acupuncture physician. We are, by statute, primary care providers, meaning that we are like your GP, your general practitioner, your family doctor, who you would go see for pretty much anything that's not an emergency, right? So we would be able to provide or order labs and imaging. We can provide treatment. The difference is here, we would not do, obviously, surgery. We wouldn't be the ones in charge of vaccination, nor prescribe pharmaceuticals or narcotics. Everything we would do would be through integrative therapies, where it'd be acupuncture, herbal medicine, manual therapy, physical therapy, diet therapy, all of that consists of potential therapies that are on the integrative scope that do not deal with specific pharmaceuticals that are regulated and are within the scope of MDs in specific or DOs. Now, the reason why this I wanted to touch on this was because the general public doesn't have very good awareness of what acupuncture is, even much less who to go to receive acupuncture and how to determine if the person is qualified or not. And believe it or not, even medical doctors or the healthcare professionals in the medical field have trouble with this as well. And at the very beginning, in the very first couple of years, I found this surprising. Fortunately, I've built many relationships over the years, and anyways, this is still an actual problem. There isn't a big awareness, and so many people don't know even if it's safe to send or to refer their patients to an acupuncture physician, because they don't know what kind of education they've gone or what kind of training is needed to provide acupuncture, which is it's a good concern to have, because within the spectrum of people that insert needles in you, there are big differences. Now, I mentioned to you that in specific to be NCCAOM board certified, you have to go through a 3,000 hour 4-year level master's degree program. This is the bare minimum to get licensed in the state of Florida as an acupuncture physician and to insert acupuncture needles and use it as a treatment. However, there are those other individuals in other states where there is no regulatory board, and just about anyone can put up a sign that says acupuncturist and start using acupuncture to treat people. So it varies from, we can say, maybe 0 training to 300-hour training to the 3,000-hour bare minimum training that we have in the state of Florida. And other states, many other states have begun to adopt the same kind of standard of having a master's degree level through a 3,000-hour program and having passed the board examination, but not all states hold that same standard. Now, additionally, I've acquired a clinical specialty doctorate in TCM internal medicine. However, that's specific to me, and it's just because of my affinity toward expanding my knowledge base and acquiring specialty and advanced skills, but it is not necessary to perform safely acupuncture, nor does it do we need to require it for state boards to regulate licensure of acupuncture. This is simply just a specialty, much like a neurosurgeon would specialize in neurosurgery after they've gone through their medical training. Oh, by the way, I did want to mention that the implications of having this gap, right? So for example, there are some programs out there that offer what they call acupuncture certifications, and there's really not much oversight on it, but they'll provide an acupuncture certification for someone having gone through maybe 300 hours worth of training on needling, and they provide this to the individual, and then the individual goes out there and starts practicing acupuncture. Now, what has occurred as a consequence of this huge gap and very variable kind of training, there's been very serious injuries and just events that have had severe consequences for patients. So there's been a couple very highlighted instances. For example, the one in the Olympics, there was an Olympian athlete who was unable to compete due to an injury from an under-trained acupuncture or someone trying to perform acupuncture. There's also been cases where they, even during a course where they were teaching, so I believe it was like a 300-hour training course, and the actual instructor who had received the 300-hour training course performed acupuncture and caused a pneumothorax. So there are some severe consequences of being undertrained and then performing acupuncture. However, I don't want to be an alarmist, because it's very safe if performed within how and what is supposed to be performed. There shouldn't be any cases where or very minimal, if at all, cases where there is a serious patient injury, because it is a very safe procedure, and it's just you are taught in, of course, a rigorous training. You're taught how to avoid harming the patient, causing injury, and avoiding these very dangerous and potentially fatal instances of puncturing organs and causing serious harm. So let's move forward with that and continue on our public health conversation. So you can pause here and take a look at where you're going to be exposed as the objectives for the lecture. I'm not going to go into this slide too much. I just did it in terms kind of like for reference and for index, and just so that you know what we would get into. Now, the strategy I do want to touch on a little bit, because it should bring you some peace of mind and just allow us to approach it calmly. So we're going to be breaking down fundamentals, meaning we're going to define all of these complicated terms. What's public health? What's complex adaptive systems? And what's integrative medicine, and how does it incorporate it? What's acupuncture, or how do we incorporate it? What's the research behind it? These kinds of things. We're going to go deep into how these specific things integrate or incorporate or interact with the current state of medicine, right? Then we're going to also take a step back and reflect on the current state of the healthcare system using research and some of the evidence that historical perspectives have provided us, and use some analysis strategies to compare our measuring tools, because we need to know what we're doing to assess the healthcare system, the quality of the systems, and is it appropriate, and is it impactful, is it meaningful. So we're going to be doing some very seriously complex discussion, but you'll be able to catch up because we're going to be doing it step by step in a strategy that's condensed, coherence, and cohesive, or provides some coherence. When we're done with doing all of our analysis, we're then going to move forward and start touching on some of the propositions. What are the opportunities and also challenges, but what are the things that we can do? What are the things that are before us that we can begin to integrate into our healthcare systems due to what's been made available to us? And what ideas are out there that can potentially act as reform guidance strategies. Now, and we're going to jump right into it here, into the fundamentals. What is public health? This whole section, this whole part 2, we're going to be dealing with the paradigms of inquiry and definition. We're going to be breaking down some basic concepts and some basic terminology. And the reason we're going to be doing this is because although we have some proposed definitions and clear ideas, we may want to revisit them because they're pivotal. They're very vital in our efforts to achieving these grand scale and broad-reaching efforts. So what we have before us is the definition that the CDC provides for what public health is: the science and art of preventing disease, prolonging life, and promoting health through organized efforts. Now, that's a very clean, strong, and encouraging definition. However, I'd invite you to think about, do we know who the public is? Now, why this is an imperative question to ask is because given that we are organizing our efforts to provide health and prolong life to the public, we ought to define who the public is. So let's take a step back and let's see how this fundamental breakdown of this concept is actually quite pivotal. It's very important in continuing the conversation of creating policy and mandates if we're going to be diving right into trying to reform an entire healthcare system. So let's start thinking about who is the public that we're talking about. Now, we can take this from two different dimensions or categories. We can take this from a personal introspective or a reflective kind of aspect, asking ourselves who the public would be to us that we're trying to promote health and longevity to. Now, typically, most doctors, I would think that, or anyone in the healthcare profession, and I would think that humanity itself is inclined to want to help and promote life and health for everyone. So, in an altruistic kind of sense, we want to care for humanity itself in an international scale. However, at the systems level, meaning the system, right, and in specific the U.S. healthcare system, we have to have very specific terminology with very specific conditions and defined terms for that terminology. So the public within that context may have to be specific. Now, are we talking about everyone within the U.S. boundaries on the geographical platform or the land mass that is what we consider the U.S. Boundaries? Or are we talking about only tax-paying citizenry? Or are we including residents? Are we including immigrants? And are we including legal and illegal immigrants? Or are we just including legal immigrants? Now, this question is fairly simple because really what we're talking about is very likely through the system's eyes, tax-paying citizenry. However, there are externalities. And what I mean by externalities is that, for example, we have many great hospitals and healthcare providers throughout the U.S. And many of them, most of them are very accessible and accommodating. Now, given these two very important facts, I don't know of any doctor or hospital that, should a patient needing care be presented before them, would deny medical care despite them being an illegal or legal immigrant, whether or not within the system they are included in what is called the public. Therefore, they are an externality of the system, meaning that they will be given care even though they are not accounted for in the system. So it's a complex idea to think about. Allow yourself to maybe pause the video and sit through it, but we should consider the consequences of either side of expanding and opening our boundaries to what the public means, or constricting it and restricting it to a certain population. There are pros and cons to both, and there are very specific reasons why we've set it up in the ways we've set it up. So these are things that we have to take into account and have a cohesive connection to as we proceed in the evolvement and the development of our ideas and of our design for what healthcare should look like and what changes need to happen, or what externalities we should take, account for, or and how actually. So we're going to lay that one aside. We're going to say that we're assuming that there is an agreed upon premise, that we're all agreeing that the public means one thing. We're all agreeing that the public means tax-paying citizenry. We may even include legal immigrants and residents, and allow that the illegal immigrants are an externality of the system that place a burden on it, but they will be taken care of. However, that is the limit to the degree of which who we define as the public. So outside of the U.S. boundaries, that's not who we're talking about. We may have a personal mission to extend care beyond those boundaries, but the public, so far as the system is concerned, is concerned with that boundary. So we're going on that premise and we're going to move forward. Although you can see how maybe even that, defining that concept in and of itself, can be a very troublesome act if you're considering certain circumstances. So we'll move on from that. And we have to ask the next question. In our organized efforts to prolong life for the public, mind you, and promote health and prevent disease, do we know what each of these mean and how to accomplish that? Meaning, what is health? Now, to prolong life, obviously you need to promote the health, but to prolong life, you also need other things that can probably kill you along the way that are not specifically tied to medical care in terms of health. And disease, are we doing well at that? Meaning, do we know how to do it? And if we aren't, then is our concept of health well structured? Meaning, do we know what health really is in the context of the human body enough, so much so that we can prevent disease because we know how to establish health in the system. And if we do know what health is, and we're very well aware of it, and we can prevent disease, why isn't it happening, or what's inhibiting it from happening? But first, let's touch on what is health, because it touches on all three of these aspects which this science and art is supposed to be working on as an organized effort. So let's move on to the second fundamental question of what is health. And actually, I skipped a slide there, but before we do so, I want to go into the inquiry logic. So the purpose of this slide is to show you kind of the sequence of the questions that we're going to be navigating. So we went through what is public health at a very fundamental level, and we're going to be defining health and defining some of these other measurement tools that we have to measure the quality of the systems. But we should, along the way, always be considering what our goal is in the sector of public health and why our goal is what it is. So throughout the whole process, let's keep this question in mind. Now, we can always come back to this inquiry logic kind of diagram that I have before you, but just take a snapshot of it if you'd like, and we'll continue with our presentation. Now, I will make a note that this is a very vital part of the presentation, because it's how we've strategized the development of our conversation. This is the strategy of how we're going to get from point A to point B, meaning how we're going to improve public health by first knowing what public health is, what our goal is, how we measure whether we're successful at our goal, and what things we can do to make those changes. So now we get into the health concepts and the defining the concept of health itself. And what we find is other very strong and powerful definitions. The very first one up here that we see is provided by the World Health Organization. And this is actually quite an old definition. This is not new. And yet, I would say that we can easily say that, or we can probably easily agree that this is not quite how medicine is practiced, or rather, this is not what we see this medical decision making is informed based on. Now, we can see transitions, we see momentum, but it's been the same for quite a while. And even though we have this perhaps evolved notion of what health is, we haven't quite found a good way of applying it in practice. So in the clinic, we haven't really implemented it in a way where it shows that this is how we define health for our patients, and that we're all in congruence about how we're going to be utilizing the concept. So the state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. It's quite a mouthful. That's saying that health is not simply a vital sign, like your blood pressure reading or your heart rate, but rather that it's, yes, your vital sign, but it's also a subjective sense of how you feel, what your social environment, your mental health. And then as we move on along on more recent introductions of definitions of health, ecological determinants. So we see that the purpose of this slide is to show you that we're actually not in complete agreement as to what health means. And so we have to keep in mind as we implement these policies that we're still catching up to the definition of health and actually defining health for ourselves. And even though people like to say on various different subjects the science is settled, it's actually quite far from being settled, even at this very fundamental level. We have different ideas about what health means. If we look at the Harvard study from 2014, and this study was in regard, by the way, all the references are at the end of the presentation. And of course, you can always contact us to have the citations. But anyways, the study was in regards to dynamical complexity, which is it's a field of study that it comes from another discipline. It comes from engineering and programming and computer science, and this was something that was designed to make sense of how, for example, the weather is impacted by different phenomena, right? So there are so many variables that you have to take into account that you can't only say just one thing is going to impact the weather. We know that maybe it's pollution, it's also the solar system or earth changes, it's also seasonal and climatic changes and just natural geological changes that are happening. It's also man-made effects. So it's very complex. So meaning, if we're talking about the system, the ecological system of the climate, this is the example of a complex adaptive system. It is determined by multiple factors, not just by one, and not only by multiple factors, but by all of the factors interacting together in a dynamic way. So it's a very complex idea of weather and climate emerging from all of these factors coming in and interacting with each other, and then sustaining this kind of atmospheric state of environment, right? So we can apply this to health as well, and this is where we're going to end. Welcome again. This is Dr. Guadamuz, and in our last video we got cut short as we were trying to explain what a complex adaptive system is and how it relates to health. So let's start off from where we ended last section. So we were giving the example of a complex adaptive system as weather or climate being dependent on multiple other agents, right? Whether it's man-made pollution or the solar system or geographical changes or geological changes, and all these other factors, and how to compute them, what algorithm would be needed in order to determine what the health of the weather is, whether it's stable or unstable, and how do we impact it, and all these. So trying to formulate an algorithm that will tell us how to perform an action that will have an impact in a very specific way is the reason why CAS was, well, it's not the reason, but this is an example of how it might have emerged. And it emerged from other sciences or other research in other areas of research, right? As opposed to it being started in health or in medicine in specific. However, because it's been such a successful and well-embraced theory and concept, because it's so applicable and it's kind of common sense, like we can see it, they've begun to have an interdisciplinary approach at trying to resolve this issue of defining health. So the concept of health has been a subject of study for a very long time, obviously, and Now, with current research, we're seeing that what's emerging is more and more is being suggested that health should be seen as a complex adaptive system itself. Now, what does that mean? Taking the example of climate and weather being dependent on so many different variables, health is also dependent on various different variables. So, as opposed to having a reductionist and linear and narrow approach at defining health and impacting health, meaning focusing on a specific hormone level or a specific chemical or a specific vital sign and keeping it within a certain range, we are expanding our definition of health and our appreciation for what impacts and what determines health, and saying, well, okay, this certainly has an impact or is a consequence of health or lack of, but there are other things that interact with that also impact health. Now, what do I mean by that? Well, in the very first or top definition here, we look at mental and social well-being. Well, that means that we're not only looking at, for example, excuse me, levels of serotonin and endorphins and dopamine levels, but we're also looking at the subjective sense of well-being. So what's the quality of life of the patient? Are they're meaning that their dopamine and serotonin and endorphin levels are not subject to a genetic disposition. It's not their constitution. It's not just that they are sick or they are diseased and so they are always like that. It's perhaps a consequence or an interdynamic consequence of a wave of emotions, of riding through life. And so having a fluctuation of all of these chemicals and hormonal feedback systems going up and down the loop of life. And so the health or the stability of well-balanced health is actually dependent on both, yes, we can measure it partly through this reductionist and linear protocol kind of range structured view of establishing what levels of what chemical or hormone the person is in, but also what the quality of life is, what their emotional state is, what their spiritual practices are, what cognitive exercises they perform, what physical activities they do to elevate these other. So everything is interconnected. And so this is what we mean by a complex adaptive system. It is much more versatile than simply having to look at one thing as a determinant of health. So it's very important that we remember that although when we go to the doctor, we get lab work and imaging and have all of these bioinformatic and metric findings, these may not be specifically what determine our health. And so if that is not exactly what determines our health or solely determines our health, then we need to take a step back and have a broader approach at how we deliver medicine and how we deliver healthcare, and how then, of course, if we take a further step back, how we implement policy from the standpoint of this defined concept of health, as opposed to the concept of health being defined by a specific parameter of blood pressure readings or heart rate readings. To give you an example, again, we point to the Harvard study where they're using dynamical complexity. One of the examples I remember our professor using a while ago about how the MSC, which is a multi-scale entropy, we're not going to go into that, but basically how dynamical complexity came to be important in terms of defining health was through things like heart rate variability. Meaning, a person who has a very predictable pattern you could take any vital sign, and if they have a predictable pattern over a long time series, you can sort of make a sound hypothesis that they will have a short lifespan. because they have no demand and challenge of adaptability, meaning that they won't adapt to stresses and challenges that the environment would provide. So they would not survive. And this is true of other ecosystems or other complex adaptive systems. So in order to keep the integrity of a complex adaptive system, it needs to be dynamic and be able to adapt to its external challenges and keep an internal balance, which is where this definition comes from. Yet, however, it's just simply applied to a human body. So a healthy human body is able to adapt and keep internal balance when it's confronted with different and challenging demands. Meaning that if you take a blood pressure reading and the blood pressure reading of the patient, you have an XY graph, right? And so you take the reading of the patient, and this group of patients showed a blood pressure reading that was like this. It was very predictable, right? Obviously, this is an easy way to predict because you're like, whoa, that blood pressure is going high and high and high. This person is going to burst. So obviously, there's a parameter. There's boundaries within which you can clearly demarcate that there's lack of health. However, simply by the pattern, the predictable pattern, you can tell that there was no variability. Likewise, a patient that was going like this in their blood pressure reading also was predicted to have a short lifespan. Also, a patient who was like this also appeared to have a short lifespan. However, a patient who had high variability and plotted all over the place had a high chance of survival and showed keen abilities of adaptation. And so within obviously certain parameters. And so this predicted a long lifespan or an ability to have a long lifespan. And so this is what their studies were finding. And this provoked the need for a new definition of health, because we no longer can accept that this reductionist way of looking at health is how we're going to define it. And so if we're going to be changing our concepts at very fundamental levels, we need to consider how these are going to then be, how they're going to cascade and affect to all of our different systems. What systems will have to be cut out, what have to be reformed, all of these things. So what I want to also highlight is that this study was done with relation to traditional Chinese medicine, obviously because the Taoist notion, that the Taoism coming from the Chinese culture primarily, being one of balance, of yin yang. So this was inherent in that medical system of Taoist medicine. They accounted for complexity. They promoted adaptation and a system to allow for that adaptation within the context of keeping balance. So they had already inherent within their medical model a complete system to promote adaptation within a balanced system. So, and obviously this is where acupuncture and herbal medicine emerged from. So we're going to be elaborating more on that. And obviously I have a bias for that, but the emerging science is showing that, well, we can actually incorporate, integrate, and enhance our current systems very much so from the insights that are being given and shown and brought to light from traditional Chinese medicine, Taoist medicine, the ancient doctors and scriptures and literature that are now consistent and correlate with current research. So let's move on and look at what that looks like when we try and bridge these two systems, this modern medicine with this ancient way of viewing medicine, health, and the body. Well, the marvel of modern medicine post-Enlightenment era has been just amazing. We've accomplished so much because of the perspectives that we've taken. This reductionist way of reducing the body into ever smaller parts, being able to see into genetics and see predispositions for um, hereditary diseases, familial diseases, and these kinds of developmental abnormalities that we would not have been able to do so without this kind of ideology or thinking. However, it does constrict us in a certain sense because, for example, if we're thinking in terms of the fundamentals of where this kind of thinking leads us to, it constricts the mind to the brain, and it has a very deterministic view of medicine, meaning it's going step by step by step, and it has a very linear model in which you are going to receive input, embrace information, and then also apply your treatment or your medicine. And so what happens in the integrative approach is that we're able to expand our view, and medicine is able to take a more phenomenological approach. It includes things like spirituality, religion, meditation, and that which we consider the psychoneuroimmunological aspect, that mind-body vitality, right? And so it's a dynamic way of viewing the body. And what we're proposing is that, well, we bridge these two. There's no reason why we need to disconnect or abandon. Of course not. The advances that we've made from these kind of reductionist and linear modes of thinking, but we do need to incorporate more and acknowledge that the subjective information that we gather is very relevant, is very imperative, vital, and can provide substantial features to our medical model to enhance it, thus creating a more dynamic and complex and adaptive system. And this is something that Taoist medicine already has inherently within it. So it's a medical model that we can look to find ways of incorporating and what things to incorporate into our system. So we're gonna cut. So what can Taoism or Taoist medicine or traditional Chinese medicine offer public health? We spoke earlier about Taoism or Taoist medicine having an inherent as being inherently a complex adaptive system. The medical model having features within it that could take into consideration that there needs to be adaptability of the system to keep in balance when faced with all of these challenges and external demands. So let's take a look at how directly Taoism takes these, or shows that it takes different variables into account. Well, this passage here that you see in front of you is taken from the Huangdi Neijing, again, 2600 BC. So these are ancient scriptures from ancient doctors that were already considering what right now we're correlating as a complex adaptive system when we are correlating it or associating it to health, meaning that they were already considering that health was a consequence of a multifactorial system. If we take a look, this is, by the way, the Huangdi Neijing is considered or referred to as the Yellow Emperor's classic of medicine, something like that, I believe. And it, in its first chapter, one of the first paragraphs, this is one of the phrases it has, and this paragraph here in specific is the Emperor Huangdi speaking to Qi Bo, which is his, I guess, prime physician, or I forget. I read this a really long time ago, and so I forget. But I know Qi Bo is responding to the Emperor, which is one of the top physicians, and he is stating how the ancient communities and their elders were said to have lived very long lives. We're here saying over 100 years. And by saying over 100 years, later on in the book, they actually define what that means. They don't only mean living over 100 years, they mean living over 100 years and working in the same things that they were working in their whole lives, meaning that they had high quality of life and they were as strong as they were when they were dying as when they were maybe in their late 30s, 40s, 50s. So this is a very bold statement. Now, we won't say to take it at face value, although I think that it can be probably verified if we apply this in our daily lives. But at the very least, we can appreciate that their prescription for a long life is very common sense and applies very much to our current understanding of what a complex adaptive system looks like when it's applied to health and to the human body, and if we were to take it as a medical prescription. So they ate a balanced diet at regular times, arose and retired at regular hours, and so on and so forth. All of this comes from acupuncture's platform. This book is the foundational text that we learned throughout our curriculum. This is obviously just one paragraph, but this is the context that we're learning medicine in the integrative paradigm, right? So we're already taking these aspects into consideration, and acupuncture is actually simply just one of the tools that we use to reestablish a balance, to reestablish harmony within the system. And we're going to maybe talk about that in more depth later. But here we're talking about specifically the concept of health from the ideology or the mindset of the Taoist doctor, coming from 26 BC. So taking this into account, we can appreciate that there may be things that we can incorporate from these. So integrative medicine doesn't only mean taking from different disciplines, but also taking from different ages, meaning we can look to the past and appreciate that there's something there to be offered. So let's take a look at what Taoist medicine actually can offer, and we can find this specifically through the research that's been done through its diagnostic model. So the Taoist medical model has a specific diagnostic approach, and it's called syndrome differentiation, or one of them at least. Syndrome differentiation is a culmination of different causation theories and or observation techniques, and each of them have certain implications. And so bringing these together is what syndrome differentiation uses to arrive at a diagnosis. Now, leaving that aside, I want to make it a little bit simpler than that. Research is showing that syndrome differentiation can actually enhance our medical diagnostic system currently today. One of the studies that was done to show this, it's very interesting. I was very excited to read this research. It was recent, and again, the references are at the back, or we can share them with you if you contact us. Was with rheumatoid arthritis. So allopathic medicine, the biomedical way of diagnosing rheumatoid arthritis, was provided by MDs and biomedical doctors. And so there was a group of patients who was categorized as RA, right? So rheumatoid arthritis. They were the biological markers and all of the correlating subjective features and symptomatic and syndromatic evidence was there to label these patients with rheumatoid arthritis. So they had that group, and what they did was let me give a little background here. So if we diagnose a patient or a group of people with rheumatoid arthritis, that's about it. That's what we have for those patients. You are diagnosed with rheumatoid arthritis. This is what we can do for you. these are the medications, or these are the techniques, and these are your recommendations. Now, what Taoist medicine comes in and offers through syndrome differentiation, it says, wait a minute, we can further subcategorize these groups and allow these patients to be seen through an individual and customized lens, so that we can provide them with a personal treatment plan. Now, they use only one dimension of syndrome differentiation, but it was very effective. And so what they did is they subcategorized, excuse me, they subcategorized the group in two sections. So they had a cold group and they had a hot group. So you have one whole group of RA, and then they took these two groups, and they took this one group and divided it into two: a hot group of RA and a cold group of RA. Now, let me explain how they did that, why, and what that means. One of the ways that we diagnose through syndrome differentiation is appreciating if a patient is impacted by what we call a cold phenomena or a hot phenomena. Now, the patients in the RA group, in the rheumatoid arthritis, who were categorized and subgrouped in the cold group, so they were patients afflicted by the cold phenomena, were patients who were aggravated, their pain was aggravated by cold, their pain was alleviated by heat, they had stiff joints, and there was no apparent redness or anything like that in the areas of pain. And probably some other features as well. We're not going to get too deep into specifics. The other RA group, the hot group, was the features that apply to the hot group are that the pain is aggravated by heat, it's made better by cold, and they were showing redness and intensified pain in the regions of pain. So that was the hot group. And again, there's many other features that correlate to what we call hot phenomena, because it's syndromatic. So it clearly demarcated two groups. Well, what happened was very interesting. When they subcategorized these two groups and they reanalyzed lab work, the cold group had specific biomarkers, receptor sites that were like DNA receptor sites that were specific to the cold group, and there was equally a distinct difference in the hot group. So you can personalize diagnose by further subtyping diseases using syndrome differentiation, which means what? Means that we can also use more personalized treatment as opposed to just giving one treatment to the whole RA group. And this is what Taoist medicine can offer, along with a host of other things, as we continue to research and find different bridges of how to connect this reductionist model to this phenomenological and broad scale and global way of viewing medicine and health. So let's move on. Now that we can appreciate that at the local level, at the level of the individual, health is a phenomena of a complex adaptive system, meaning that health is dependent on multiple variables and agents interacting so that health can emerge. We can then obviously deduce that public health is similarly a phenomena of a complex adaptive system, meaning that the health of the public as a whole, or the health of the healthcare system, is dependent on multiple factors. It's dependent on available. Well, so let me explain a little bit about the model that we have before us. This was a study done by some public health professors back in the 1980s, and they came up with a system to measure how well we were doing with our healthcare system. And so they said accessibility is important, right? So here we put quality of care as the central point, but accessibility was the main driver in the research when this kind of these outer terms were selected. So public health is a complex adaptive system that is dependent, or it's determined by 5 major agents. Now, this is my deduction from it. I think that there still needs to be obviously much further research into it, but public health is dependent on availability, accommodation, affordability, accessibility, and acceptability. Now we can define each of these, and we can find that they match at the local level, and they also match at the broader global level, or at the community level of the nation. If we look at availability of a doctor, are there enough doctors, right? So is there a doctor available to give you treatment? At the broader availability of public health, is there enough food? Is there enough resources to provide the public with the obvious resources that are needed to keep the public healthy? Accommodation in a at the local level, does your doctor's office speak the language that you speak? At the broader level, is the housing, is your neighborhood safe? Is it healthy? Is it conducive to health? Affordability, is there the money for the patients to pay for doctor's visits? At the broader level, are is there enough taxes to pay the physicians, right? Are we bringing in enough in revenue, in tax revenue, to provide for our public goods? And accessibility, same kind of thing for each of these, but specifically also for acceptability, meaning that is the quality of care acceptable? And this is obviously at the local and at the broader level, and how we measure that is very important. And it's a question that we must ask and not be dismissive, taking it for granted as a simple question and give a simple answer to. Public health is a complex adaptive system phenomena, and if we dismiss it and give a simplistic answer, we run the danger of making. So we move forward, and one of the, I think, primary questions that we have to ask is, well, if we know that these are the elements that provide public health, or account for public health, or determine public health, how do we measure it? It's a very complex system, and how do we account for, how do we make sense of all of it? Well, let's move forward and let's take a look at what's already being done, and see if we can make sense of it and try to improve it. So we've already talked about how public health is a complex adaptive system, and it's dependent on diet, on stress, on your lifestyle. And we also earlier touched on public health being determined if we are, based on the CDC's description or definition, trying to prolong life, not only determining it by the healthcare or the medical delivery, but rather also other determinants. What other things can kill you? And we'll touch on this later on in the presentation or in the lecture, as we look at life expectancy and the actual mortality rates and causes of death, or the leading causes of death. But before we even get into that, let's ask ourselves, how are we measuring the state of our healthcare system, or the state of any healthcare system for that matter? How do we measure it? How do we know what the quality of public health is? How do we know what the quality of the healthcare system that we have is? How do we determine the quality of our medical delivery system? Well, one of the ways, this is not the only way, there are different institutions, agencies that work day in and day out to resolve this very problem and provide us with in-depth research. But one of the main ways, and one of the obvious ways that we determine the quality, or we assume what the quality and the state of the healthcare system is, and how good we are at providing public health, is by life expectancy. So mortality. So we are measuring public health by our ability to keep people alive. And I think we know very well that there are different variables that account for people staying alive that are not medication or health insurance or any of these other direct things that associate with medical care. So as we continue this conversation about public health policy making and reform, we have to also continue to take into account that we're not, we still have not found the perfect way of measuring the state of our healthcare system. There are many factors that come into play and many variables that we have to control for. So in reading research, in pulling up different studies to determine and to say, well, the healthcare system is poor and you can see because of this, we have to take that with a grain of salt and we have to look at the different controls that are being accounted for and how they're being accounted for, because there's many different variables and also various different causes for the variations in the results. So if, for example, we are going to assume that, or we see based on data and evidence that life expectancy is very poor and short due to a certain disease, it's easy for us to make the simple assumption that, well, our healthcare, our medical system is failing because we're not able to treat that disease. However, it may be that, well, what we should ask perhaps is, well, why is that disease so prominent in the first place? Because obviously, or maybe we're actually we're capable of treating the disease, but we shouldn't be worried about treating the disease. We should be worried about preventing the disease. And so medicine becomes prevention. And we've heard and we see the memes and we know the quotes, and it may be cliche, but it has a very real impact and correlation to what we're talking about now. And so policy making and the considerations that come into play about when we start having the conversation about public health become more about the causes of these diseases as opposed to the care and treatment and management of these diseases, because what we're trying to do is have a real impact, a meaningful impact on these things. So we'll continue and keep in mind that we're not quite there yet when we try to determine how to measure the quality and the measurement of how successful we are at providing healthcare to our public. Now, one thing that I will say, I think that MSC, which is a multi-scale entropy system, CAS, when we look at complex adaptive systems and other disciplines revolving around this systems network and CAS and dynamical complexities kinds of theories have a lot to offer us with relation to how well our healthcare systems are. So as opposed to our traditional measurement systems of life expectancy, mortality, leading causes of death, and so on and so forth, there may be other more complex algorithms that we can computate that will give us a better measurement of the state of our healthcare system. Now, again, of course, this is not the time for it, and I'm not the specialist or anyways, that's not my field. So, but I do think that this is one way that we can improve how we measure these things. So, taking into account all of the knowledge that we've become aware of and all of the different variables, we come into a more broad approach. We take a step back. We take all of that information, we synthesize it, and we begin to assess it. And we say, okay, let's take a look at the actual healthcare systems. What are the systems that are out there now? And let's ask some fundamental questions at the broad level. So, who's responsible for public health? That's a very good question because it gets answered and there are different systems that would probably respond to it differently. For example, social systems in Canada and the UK very much are inclined to, or based on their policy, suggest that government is responsible for the public's health. In the US, we're maybe conflicted. Our current policy is nor here nor there. I would say probably more leaning toward the socialized system. And I'm not suggesting yet whether that's good or bad, but the private system offers, of course, a completely different system than the socialized system, and suggests that there is more personal responsibility for the health of the individual as well as the health of the public, to providing your common man, your neighbor, and your community with respect and your services that can maybe help them with health. So, based on our current US healthcare system, it's about 70-30%. That's not an exact number, but if we take a look at the current system, we can probably say that for a very long time, we've been leaning more and more toward the social system. We've been leaning more and more toward suggesting that the responsibility of the public's health is on the hands of the government. Non-existent hands, I don't know, but anyways, so when we're looking at Medicaid, Medicare, the ACA, which is the PPACA, the Affordable Care Act, when we're looking at the VA, veterans, the veterans care, when we look at, I mean, I can't think of now, but welfare, right? So many different kinds of caring for the public, considering different things common goods. We are showing by action and by vote and by policy that our belief is that it's the responsibility of government to take care of us. And so we're going to look at the different systems and how they emerge, what their key, I guess, we're just going to take a look at their systems. So when we look at the goals of the social system, it's based on equality, equity, making sure that everyone has an equal result or equal outcome, right? Here we have the Constitution. It provides both, meaning freedom and equality. On the privatized or on the libertarian or on the more free enterprise, free market kind of system, we're looking more at not worried too much about providing equality or equity, but rather assuming that equity will emerge from the equal opportunity, right? So here we are more concerned with providing equal outcomes, making sure that everyone has access. Here we are more concerned with providing equal opportunity. Here in minimum wage, what we're talking about is, let's say everyone has in a social system, everyone is insured or guaranteed a certain amount of money. In the US, our current policy has a minimum wage. The privatized or the free enterprise or free market system would have it that there would be no minimum wage, and so that everyone would have an opportunity to make money. And so one of the arguments against minimum wage, for example, is that it cuts out the opportunity for low level potential employees. It cuts them out of a possible job, because they're unable to get a job. When an employer would be able to pay them for their low-level skills, and they could advance themselves through that, we cut them short because we provide a minimum wage, and no employer is willing to pay that minimum wage for a low-level skill. We can look at Milton Friedman, Nobel laureate economist, and Thomas Sowell, which make fairly good arguments in regards to minimum wage. And this is obviously impacting health and public health, because many of the concerns that we have with regards to individual health, or when we look at people who are dispossessed or are, let's say, on the lower end of the socioeconomic status, are affected by poverty. And so we inherently can see the connection from poverty to low health outcomes. However, here the argument is, or from the economist Milton Friedman argument, is that poverty is a problem of money. It is not a problem of health. So if you want to fix health, if you want to fix ill health that is due to poverty, then you need to fix poverty, not try and make access to care free. So there are some dire consequences to each of these, and here in the social aspect, that one of the major things that is being considered is the moral hazard, meaning that if it's free, if you have social care where you can get treatment anywhere, whenever you want for whatever you want, you will go and do so as often as you can for just about whatever. And so you will burden the system. And this is such a prominent issue that it's an actual term that economists use and take into consideration when they're considering the impacts of certain systems. Basically, that there would be no consideration by the user if it's free or it's being paid by someone else, as opposed to, let's say, a free enterprise system, or a system where there's individual responsibility and the individual has to consider the cost. And so the individual would negotiate a better price or a better fee to pay the least and not have to pay out the most, which would mean that they would try and limit their visits or use of their insurance policy or whatever it may be. In the US, or the current policy that we have here in our healthcare system, again, it's a hybrid system where you can participate in the national insurance and healthcare system, or you can purchase your own. I would say that based on my experience with the ACA, my patients' experiences with the ACA, and the doctors that I interact with on a daily basis and have interacted with for some time and communicate with, in large part has been that it is largely more of a burden and ineffective, and has dire consequences, although it provides some substantial benefits to people in the lower socioeconomic status, in that it provides them access to care, to have specific treatments given, and without them having to worry or being stressed about being able to pay it, because it's guaranteed to be paid by this system. Now, the caution that we have in this system, or rather the benefit there that is produced from this system, is said by the free enterprise ideology that the lower socioeconomic status individual would have access to that care if there were actual free enterprise that were unfettered by the government, because there would be competition, and competition would lower the cost. Let's move on. Here we have a single payer method, meaning that only the government is paying or is in charge of public health. In the US, we have a hybrid system. Again, we have the ACA, but you can also get private insurance. And in limited government, or in the free enterprise system, there would be no government interaction, and so everything would be negotiated, whether it be that there's no insurance, or that even the insurance rates would be negotiated. Now, there is a lot to be said within this conversation, and it's a lot to do with the economic policy and monetary policy, especially when we start getting into this lower section here with welfare and patient protection, because it guarantees certain things that burdened that burden the system bureaucratically and also economically. And we've already talked about how all of these different variables directly impact public health, but how poverty and lower socioeconomic status and being dispossessed in the system is not it's a money problem. It is not a health problem, meaning that the problem of the individual not having access to healthcare is not a healthcare problem. It is a money problem. And so the way to resolve that is through providing an opportunity for the individual to negotiate better fees and to grow their income or grow their capital or grow their ability to make money, and raise their economic status. And that conversation is being had and debated all over the place. So here we have in the social system a high tax rate, that which it has to be so in order to pay for all of the common goods and social systems that are going to be provided. In the U.S., the current policy, we have such things as welfare. We provide certain housing, and WIC, for example, where we provide food and things of that nature. And Milton Friedman once proposed a negative income tax to ensure that there's some safety net for the dispossessed and the disenfranchised, because they recognize that the free enterprise and the free market will have some market failures. There will be externalities, and there will be things that will have to be controlled, and some policies will have to come in to have some limited government control for these market failures. And so one of them was introduced as the negative income tax, where should a person not make any money at all, they would still be provided a basic income, but that basic income would be so minimal that no one would, let's say, be able to suggest that they were just not going to work, because it's not, people would still want to thrive. I'm not certain how, I don't know the research behind this. It just, Milton Friedman described it and was exploring it. But the welfare system is certainly burdening the taxpayer, and at the level of social systems, it's near unsustainable, provided by historical context. Yeah, we'll just move on from there. But there's much to be said along the economic policies, and they are directed to, again, public health is a complex adaptive system, and economic policy and monetary policy are things that we have to consider in terms of what the impacts are and how they directly impact public health. So, for example, one of the things that's mentioned is the creation of the Federal Reserve in 1913, was it? Directly, and I think the Federal Reserve, one of the Federal Reserve presidents, acknowledged that they were very much the reason for the crash in 1929. And by the way, you have to know a little bit about the history of the Federal Reserve, but it's a monetary policy that took the hands off of government from coining currency, which was constitutional power that I believe Congress had, and it was given to a private. It's a hybrid sector, like it's privatized, but it's not quite privatized. It's kind of confusing there. But anyways, because of the crash, Medicaid, Medicare were instituted, or something like that. And since then, we've had Medicaid, Medicare, have been off of the gold standard and have had runaway debt. And so inflation and all of these things have been impacting individuals and pretty much provided more and more negative consequences toward lower socioeconomic status individuals. Now, one of the big things to note here is that the Medicaid and Medicare services, again, are overburdened, and the administrative costs or the cost of these services and these public goods have outburdened the system, how they were structured, and so they've gone into um, different sources of income, so they go directly into the taxpayer as opposed to how it was funded previously. One of the other things to point out here is that during that time, one of the presidents, I forget who, instituted a law where to try and balance healthcare and to try to incentivize employment, because employers needed to employ people, to create an incentive. They tax exempted insurance for employers. So your employer was able to offer the companies were able to offer the individuals insurance as an incentive, and the company would be able to provide it tax free. And so, whereas the individual had to pay taxes on it. And so obviously that shifted the way that the market negotiated health insurance, and there's been substantial, we'll say, negative consequences due to that. So, talk about a little bit something like a personal story. I was talking to my son, who was sitting at the kitchen table when I brought up the subject of public health and what I would be talking about it, and he asked, what it would be about, and I said, well, it's about who should take care of the sick. And so he said, well, doctors should. And I said, yeah, absolutely. And so he said, well, I asked him, and who should pay for the doctors? And he said, well, doctors should do it for free. And I thought, that's great. I agree. It would be really nice if we could care for people for free. However, I then asked him, well, what if people lined up at our house and were knocking, and it was mandated by law, or I had to treat them for free? And he said, oh no, but not you, because you're poor, or you have to pay for my things, or something like that. And so it creates we have this moral dilemma, because we want to be able to say that we are acting morally and have this ideology that we're going to actually care for everybody, but it's not sustainable when we consider that we have selfish needs, and we're greedy to a certain degree, and want to be able to grow economically. So anyways, the scenes were a Jewish sect, said to have lived communally, as basically a communist kind of society. They shared all of their income, and no one owned anything. They were the originators. They're said to be the originators of hospitals because of their hospitality. So they were a Jewish sect who were very religious and had very strict doctrines. Of course, this was I'm assuming this was a voluntary priesthood kind of community, and they established centers or houses, and they were very hospitable to their neighboring communities and individuals. And through that, they began to be able to take care of the sick, and they did this, is said, for free. And so this is where hospitals have come from. And I mentioned this because as I was speaking to my son, this was something that was very, it was a moment to be nuanced with my son, recognizing that in our current system, or in any system and at any time, you would have to make a very deliberate, conscious, and profound decision to say, I'm going to dedicate my life to providing for the sick, and go Mother Teresa style and not worry about any money. And it's very virtuous, admirable, and I mean, it is the epitome of what humanity is capable of. But also, we have to face the reality of having a family, of providing for the family, and living in our current U.S. system. And basically the global system, the global economic system that's uh, in in the works right now. And so it was an opportunity to say, well, it would be really nice if we can afford, care for the sick for free. But you know what? We have something that's almost there. We can have charitable care. So we can charge for our services and then set aside one day where we open up our doors to anyone and everyone and provide as much free service as we possibly can, and then return back to our services for fees later on. And so this was this is a very interesting conversation, and I just wanted to highlight it here because I thought that when talking about a free enterprise system or a socialized system, we get caught in the extremes, and then we also forget that there are historical perspectives that can shine a light as to different the different richness that different cultures can bring to us. And really, that there it's a nuanced conversation that we can't just shut out ideas. However, we do have to uh, take into account the complexities. And so again, I've been saying that throughout the whole lecture, but I think that it's something worth saying that much. So let's move on. One of the biggest and most cited, I guess, concerns that we hear about the U.S. national healthcare system is how much we spend. So this was taken from, I believe it was the CDC. Uh, it's a very public number. In 2017, it was $3.5 trillion what we spent on healthcare, and it was $10,000 per capita, meaning per person. Now, this is the most. This is that we spend. We're one of the countries in the OECD, which is the developed countries that spend the most, but is targeted for, or is highlighted as providing the least effective care to our community or to our public. Now, some of the um, some of the facts that were, this is from the Department of Employment fact sheet. Yeah, so the references and the citations are further along at the end of the lecture, and I can provide you the articles again, as I've said earlier. So some of the things that have been noted as causes for such high and extreme expenditures are the rising costs of healthcare. So not only doctor visits and how much doctors charge, but rather that the technology has gone up and advances, and so those are like really runaway prices. Prescription drugs. This is something that's actually unique because in other countries, prescription drugs are quite cheaper, and it may be due to the FDA and how they control the research and the I guess, availability of the drugs. And then, but also one of the biggest is administrative costs. As you can see here, it was estimated that $361 billion was spent annually on administrative costs. And it's not that it was just spent and that it was administrative costs, but that it was wasteful. Um, this is a huge amount to just be wasting, and we can probably do a lot better. Now, considering that it's administrative costs, we would assume that most of this is bureaucratic, right? So we are taking into account that this is Medicaid, Medicare, ACA, the veterans. All of these have so many levels and so many dimensions in the hierarchy system, and so many bureaucratic, ineffective communications, that it costs all this amount of money. And in with respect to a conversation coming from a free enterprise point of view, the number one thing that you would try to do is cut costs. So the argument from the free enterprise is that, well, of course, administrative costs are high because there's no incentive to cut the costs from the company who is administrating the business. Because if the business were in charge, and in a free enterprise system where it had to sustain itself through being profitable, it would surely make sure that it is not having $361 billion in wasteful product, or it would fail. The system would be allowed to fail. So this is, in citing free enterprise systems, these are one of the things that we have to keep in mind when we're comparing it to, let's say, social systems. This is something, again, that I heard Milton Friedman say, and it makes total sense, and it's something that you come to on your own terms, but you also, when you hear it come from such an authority, because he's done so much research and provided so much to that field, that it substantiates the claim that one of the biggest advantages of this free enterprise system is failures. Is that when companies are allowed to fail, bad products and bad services are eliminated, as opposed to the bureaucratic system or systems that are public or government funded. The government tends to not cut its own departments, of course, because it has many incentives not to do so at every level. So these are things to consider. Now let's move on, and we're going to look at leading causes of death. Now, obviously, this is the most that we can connect this the most to public health, because it's such a direct correlation, right? So when we look at these are, by the way, the 3 top leading causes of death. And these numbers, again, were taken from very public and accessible numbers. This in particular was, I believe, again, the CDC. Yeah, it was the CDC, I believe. And so we have heart disease as the number 1 leading cause of death, cancer following, and accidents or unintentional injuries being the 3rd leading cause of death. Now there's a big gap between accidents and these 2 other leading causes of death, but it should be alarming that we're going to be measuring the quality of our healthcare system, yet the 3rd leading cause of death really is not due to actual medical delivery. And so if you're going to be comparing apples to apples, or suggesting that the healthcare system is not working, and you're measuring it based on life expectancy or mortality or mortality, then we might have to control in a very large way for unintentional injuries. Now, these other 2 are diseases, are chronic illnesses that are very preventable, things that we know the risk factors to, and yet we don't do much about. And so, and as a culture, as a community, so what we're seeing is that what the question should be is this a cause? Is this a cause of lack of medical delivery and lack of healthcare, or is it a lack of quality culture, a lack of societal impact, a lack of actual care? So, when we think about the risk factors for heart disease as being obesity, this is due to over access, if you would. So we have to consider that, again, I mentioned this earlier, that we may have to shift our concerns over to prevention as opposed to treatment, as opposed to seeking how to pay for drugs, as opposed to seeking how to pay for health insurance or coverage, trying to go for more campaigns and kind of strategies that focus on prevention, on actual quality healthcare, meaning that our medicine is gearing more toward preventing these diseases. So these are our leading conflicts. Like, this is what we cite as being the most troubling when we think about the U.S. healthcare system. As it mentions up here, U.S. spends considerably more on healthcare than any other OECD country, but lags in life expectancy. Now, it lags in life expectancy, yet these are the leading causes of death: preventable diseases and accidents. So we have to take this into context when we're drafting policy. So we're going to move on here, and we're going to look at some of the proposals or some of the strategies that have been put into place. Now, this is in the UK, where they have a national healthcare system. And so what they did is they did a study because they had poor quality healthcare, meaning that there was long wait times. And so in order to shorten the wait times, they decided to see how they can incentivize the doctors to improve the quality, because they found that patients wanted providers who provided greater health gains, right? It's not a, I don't know that we needed a research study to conclude that, but anyways, it concluded it. And so what they did is they started incentivizing providers to increase their quality, or what they provided as medical delivery to be higher of quality, and it resulted in unequal access. So they started the NHS to provide to kind of have equal outcomes, equal access. They found that trying to do that was unsustainable and actually provided poor quality care. So they tried to incentivize it by simulating competition, but that simulated competition actually returned them to the initial problem that they were trying to resolve. So it's very conflicting when you look at the research and the propositions and the strategies that have been taken into place, that have taken place and have not resulted in what they thought it would. So we are here having already talked about U.S. healthcare expenditures, the leading causes of death, and having touched on many of the determining factors that are rising the cost of healthcare in the U.S., making the U.S. Showing the U.S. in the light of providing what we consider a low or poor, or having a poor U.S. healthcare system, while we're spending astronomical amounts. So we are the objective, or one of the objectives in our efforts, our organized efforts, as we call it in public health, to improve the healthcare system, is to obviously lower costs. And so we have here different ideologies on how we would accomplish that. And we've touched on some of the consequences of different systems, of how that would have the different systems would have on the quality of care for individuals and the public at large. But here we're going to talk about direct cost impact from those systems, or the ideologies at least, and in how they go and how they create policy. So obviously, making here a common sense statement. The National Healthcare Quality and Disparities Report says making care affordable requires smarter spending, and seeing as administrative costs is one of the and wasteful administrative costs is one of the leading factors in making U.S. healthcare so expensive. That we are obviously doing a poor job at spending smartly. So we are looking at the two general ideologies that govern our decision making for policy and creating mandates, and one of them being more government and the other being less government. Now, on the side of more government, we are looking at things like patient-centered medical homes and the ACA, and funding publicly through Medicare, Medicaid, the Veterans Association, all of these different publicly funded healthcare systems. Patient-centered medical homes being one of them, introduced partly through PPACA. So when we afford everyone a patient-centered medical home, it's kind of guaranteed. We assure, let's say, access, but going back to one of the previous slides, we make moral hazard a possible consequence. On the side of less government, the free enterprise system assumes that would the free market be unfettered, the price would lower because the competition. So much like in, for example, the eye health and cosmetic world of medicine, prices have lowered because there's been a deregulation or defunding. The different medical companies have had to compete for the business of their patients. So both have strong arguments, but if the goal is to lower costs, definitely the bureaucratic systems don't have that as a priority, or it just wouldn't. They don't seem to be the most effective at doing that. So looking at an integrative way of looking at public health, or let's say rather what the Taoists would suggest in terms of policy, they obviously tended toward less government. So there are many more quotes like this, and they stem from the Tao Te Ching. Again, we're talking about texts from Taoism that are dated back to past 2600 BC. And we're looking at things that are saying things like the more subsidies you have, the less self-reliant people will be. This is touching on the previous slide. We were talking about responsibility. If your public is less self-reliant and feels less responsible for their individual health, and kind of assumes that the government is responsible for their health or the public's health, we can assume that there will be more dependency, and that dependency will in turn be in consequence be less health, because they're just again, it's moral hazard tied to kind of like irresponsible, unaccountable way of living that it just naturally ends as a consequence that people will be less healthy. And obviously, if you're taxing more to provide for these public goods, there'll be less incentive, there'll be less growth, less economic opportunity. So this is a very ancient scripture, yet it's sounding very much like what the same debates have. It seems like the same debates have been going on for a long time. So where are the opportunities? What are the challenges? And what are the reform propositions? So let's talk about possibilities. Coming into this lecture, I noted that it was as if the development and unfolding of my presentation would be the antithesis for public health itself. However, that doesn't have to be the case, because I engage in public health in a private way through my practice. And I think that this is something that this is a huge possibility. There wouldn't be an absence of public health would it be given to the free enterprise system, or at least leaned more toward a privatized sector, rather that it would take a different, it would be an innovative way of providing public health. So I think that we have to consider more what are the opportunities for the private sector to provide public health. Public health. Now, something else that we have to consider is bringing along the wisdom that is afforded to us by different cultures. And one of the things that has been coming up is urban acupuncture. This is designing cities around the concept of efficiency. So this is something that was key in the Neijing and the text that we referred to earlier on that the Taoists used. They used geomancy or feng shui. Now, feng shui, we think of something fancy, luxury, and about the home, but in essence, this was used for their agriculture. They would make sure that they design their communities in a way that water flowed so that their agriculture would be most effective. So these, in this respect, we have access to water, but maybe we don't have enough parks or enough greenery or enough nature or enough access to those parks and nature. So starting to incorporate designs that take this into account are ways to incorporate urban acupuncture. Now, I really invite you to take a look at urban acupuncture. There's many movements that are going on that currently around the world, taking on this kind of philosophy. And of course, incorporating Tai Chi, Qigong, herbal medicine, these kinds of things. However, I touched on the very fundamental aspects of public health because, Sun Simiao, this is an ancient doctor. He's called the king of medicine in China, the king of the king of medicine. And so he stated, and this is one of his famous quotes. He said, "Before administering acupuncture and herbal medicine, take care of diet and lifestyle." And this is key in individual health, but it's key in public health. It's key in policy making and mandates. Even though it's an incentive for me to be an advocate and encourage the introduction of acupuncture, Tai Chi, Qigong, herbal medicine, and integrative medicine to be incorporated into the public sector and to be funded publicly and to be accepted by Medicaid, Medicare, ACA, all of these things. That's not how we're going to solve public health crisis. We have to look at fundamental and foundational problems and challenges. And although all of these things will help astronomically, acupuncture with PTSD and relieving and alleviating pain and helping with addiction, and Tai Chi and Qigong increasing breath awareness and mastery, and therefore eliminating chronic illnesses and all these kinds of things. What we're talking about there primarily is we're wanting to change culture. We're wanting to change, invite others to take responsibility for their health and educate around these concepts. Now, some of the things that we have to account for that may be the free enterprise is going to miss are the market failures. And we have some examples of that going on right now that are very drastic. We have the EMFs, the Wi-Fi, the screen time. We have cookware that's leaching into the food. We have the organic tax. Organic foods are high, cost more. We have toxic contaminations of the water, of the air, of whether it be in medication or different things. Those are things that the companies have to be held accountable for, and we have systems in place already to do that, judicial things, litigations, and all of this. So we just have to enforce it. And also maybe develop new policies that account for these kind of new problems that are emerging. For example, EMFs. EMFs are a real concern, and we have to, have some research around this so that we can learn how to navigate this new technology and advance with it, as opposed to just, try to go through it as it really impacts our health in a negative way. Now, one of the things that is probably universally agreed on, and I don't know of anyone that would disagree, is breathing mastery. If we can focus on something that we can all agree on, such as improving and enhancing optimal breathing, and providing this skill just universally, I think that if our focus is truly to improve the health of the public, to improve the health of the individuals, there's nothing more fundamental, more easily, and just more something that we can agree upon than breathing. If we can create a campaign, if we can campaign for breath education and going about this is something that it's just going to have astronomical impacts, and very likely benefit and reduce the cost of all of these things, as we're going to have an impact directly on the leading causes of death. Now, there's plenty of research where you look at, for example, supplemental oxygenation for cancer, and breathing obviously correlates to heart disease and COPD, which is another leading cause of death. So we have to be sensible and look at the things that we universally agree upon. And we're facing the challenges. So here we have this is a highlight of some of the real challenges that we're facing with trying to integrate things like acupuncture, syndrome differentiation as a diagnostic model, and other integrative therapies that could potentially help us achieve some public health goals and really enhance our medical models. But we're faced with a lot of criticism, a lot of we'll say quackery claims, right? So there is a real need for critique. There's a real need for a call to have evidence for what you're claiming. So this is invited and it's encouraged, because there should be a dialogue as to what gets accepted into medicine and how we practice and what really will be useful for patients. However, there is a lot of misinformation and a lot of bias in the research. There's obviously many incentives to stick with current systems because they're profitable for certain people, and so there's a manipulation of research and editorial processes that help these movements along the way to try and keep the public at large misinformed, or dissuade people from actually referring to or accepting or embracing or trying out these different integrative therapies. So here in specific, the author of this page of this website is talking about the ICD-11 codes and the incorporation of syndrome differentiation kind of diagnostic codes. Now, there's a lot that can go into this conversation. I'm gonna just reduce it to one point, but basically, to synthesize what this means is ICD-11 is a international classification of diseases that we use to build to, or use the codes to build to insurance companies. And so it it lays out what diseases, what treatments are applicable, and what providers, what falls within what provider scope of practice. So what has happened is the World Health Organization and other agencies around the world have come together to put together a system where codes are included for diagnoses that are unorthodox, that are not within the traditional medical model. And so things like what we used to subtype the disease in the example that I used earlier for rheumatoid arthritis in the study, where they subcategorized rheumatoid arthritis as a cold group and as a hot group. Those would be the kinds of codes that would appear in this ICD-11, where there would be maybe a hot syndrome differentiation type of pattern, and there would be a hot or a cold syndrome differentiation type of pattern. Now, it gets a lot more intricate than that, and the whole medical model from the Taoist point of view reveals a lot of different connections and syndromes that are tied to specific treatments and have specific causative causation and etiologies that are tied to it, and possible multifactorial systems that cause the diseases and the syndromes. But I don't want to get too much into it. So basically, the research is there. So we have, and I've provided the lecture audience with the research providing evidence that suggests that acupuncture is definitely effective at treating pain. And it's obviously has more of an impact than placebo, because one of the key counter arguments for acupuncture has been in large part that it's only placebo. So various efforts have been done to study placebo. It's been a very difficult and challenging process, because to isolate the placebo effect in a theatrical kind of clinical setting where the treatment is a procedure, and so to isolate all the different variables that are happening within that setting are fairly difficult. But anyways, the attempts have been done, and controlling for placebo, acupuncture still has a significant impact on pain, and obviously with much less side effects and adverse consequences and effects than traditional forms of treatment like narcotics. So along with acupuncture, there are many other studies like the RA study. There's one for diabetes, and for actually substantiating the actual complete medical model and the diagnostic features that it provides. And so part of the efforts have been to standardize and provide protocols for these systems so that they're more easily integrated into our medical model. But there's a huge resistance coming from these kinds of mindsets, and so they present really strong challenges, and they're welcome because they actually do help refine both, I want to say, worldviews or or medical worldviews, and they actually are catalysts. These are catalysts for research. So it's great because I think in part, for example, the complex adaptive system conversation emerges from this kind of critique, and so when evidence begins to emerge that is so substantial that is undeniable, we can then have a fortified debate with supporting evidence that there's a very good reason why we would want to incorporate these kinds of integrative therapies and diagnostic models. Of course, they've gone through rigorous studies, so there's a way that we're going to be integrating it, and it's not going to be just any therapy, and it's not going to be performed in any kind of way or just by anybody. And so that's why all of this kind of refinement process is necessary and this back and forth. But it still does this kind of rhetoric is still very prominent in the field, and so it's one of the challenges that we face, and it's very real, especially because it's it's very well established in many of the medical circles. So one of the things that actually diffuses that challenge is the Acupuncture Evidence Project, and you guys can check it out at, I believe the website is acupuncturefoundation.org or acunow.org, or I'm not sure, but it's Dr. Matthew Bauer team and his team have really done an excellent, fantastic, amazing job at gathering just loads of data, along with some other amazing professionals in the field of acupuncture that have advanced the research of acupuncture, systematically brought together all of the research and assessed it and organized it so that we can show and we can really see that there's been substantial research done on acupuncture and Taoist-based integrative medicine, and that it's truly effective and it's truly worthy of incorporating into our systems. And so much of this evidence has come forth that it's triggered many changes. So for example, the CDC recently put out the statement that non-pharmacological therapy and non-opioid pharmacological treatments are preferred for chronic pain. So meaning that acupuncture, yoga, tai chi, things of this nature are going to be considered first in line options before we consider surgery and narcotics to treat pain, because of their effectiveness at treating pain. We also see many hospitals now incorporating acupuncture into their ER department. The Air Force applies acupuncture to their to their companies and to their military or to their forces. And they also there's also what's called battlefield acupuncture. You have the Veterans Choice Program that now also contracts with acupuncturists, TriWest. You have the World Health Organization, which also is providing the ICD protocols or the codes to incorporate some of these Taoist integrative therapies and diagnostic codes. And so there is a lot of movement and momentum around the Acupuncture Evidence Project, and we can see it emerging, which is a great thing. Now, one of the ways to keep it going is through bringing awareness as to the mechanism of action, the multiple effects, and really educating ourselves on placebo. Placebo is a really curious thing, and I invite anyone who's interested in the conversation to look at Ted Ketchup's my Ketchup's work and that he's done in Harvard. But basically, I'll do a very brief breakdown here of the mechanism of action of acupuncture, and there's much more that can be said, but there we can break it down into two basic systems. We have a local effect and we have a systemic effect. At a local level, we have a direct inflammatory response. It's immediate. A foreign body has entered into the field of yourself until it has penetrated the skin. The self, the sense of self, recognizes that a foreign body has penetrated, and it sends an immediate response to it. That inflammatory response is a self-healing process. It sends new cells, and it's like when there's it's a micro injury. It's like when there's a wound, the wound knows to heal itself. So you're stimulating a self-healing process. Now at the systemic level, you're changing hormonal processes, and serotonin, endorphin, and dopamine levels are adjusting, and oftentimes what's been seen is that the parasympathetic is engaged through the vagal nerve, for example, triggered by the ear, and you are inducing a state of relaxation. Now, if we can say anything about acupuncture, is that it is damn good at helping you to relax. And if there is anything that can be that can help you to relax, that probably should be considered as an imperative tool, as a vital tool in your medical kit, especially when we consider the anxiolytics and the different impacts that stress has on us, all the stress related disorders. So if we can say that acupuncture helps relax alone, that is evidence, or that is a strong enough argument to begin to implement it into our different medical models and systems. Now, much can be said about its efficacy for pain, for fertility, for menstrual disorders, for neurological disorders. It's being studied under the scope of neuroplasticity. We can talk about trigger point needling in terms of the fasciculation process that it can trigger to heal atrophy and just sequela after strokes. I mean, it goes on and on, the list of things that acupuncture can have an impact on. But really, I think something that we dismissed often, even the field itself, acupuncture, is the impact that it has on relaxation. It's something that is so powerful that even if the only thing I can do to a person is help them relax, I've done my job. If I can stimulate you to get into a meditative state, that is great. So so let's move forward. We're going to touch on one last thing, and then we're going to wrap it up, and we're going to look at reimbursement models. One of the things that we touched on when we were comparing the UK and Canada models versus the US confused model, which is a hybrid model, as opposed to what would be a free enterprise model that that would reflect more of a free market, which is unfettered and doesn't have any intrusion in the competition. It was that there are different healthcare systems that directly impact the monetary policy, or monetary policy directly impacts the healthcare system through, for example, raising costs through lack of competition. Now, here are the different ways that doctors get paid. I think that this is something that the general public also doesn't have, is not very aware of, and I would say even some healthcare professionals are not aware of, because we've been more and more detached from this process as this aspect of medicine has been, I guess, given away to government structures. So for those of us still in the private sector running businesses, we're very familiar with the different reimbursement models. So here I put, a nice little altruistic sign. So we do it for soul food, like at medical providers, healthcare professionals, for the most part, I would say, are trying to do good. They're in it not for the money. They're in it to try and help people, and really it feels good to have someone smile because they feel better, and because they feel safe, and because they feel like they're healing, or yeah, it's a really self-rewarding vocation. So it's easy to see how a charitable service would easily emerge even from a free enterprise system. But I'm going to move on from that, and we're going to touch on the actual reimbursement models and how I interact with them personally. So we have the fee for service model, which is basically what it says. You provide a service, and for that service you charge a fee. Now, this is in direct relation to insurance companies, and it gets criticized because it gives way for doctors to overbill, or to bill more services to people, and maybe even provide services or treat more than they need to, so that they can get paid more. So there's definitely a drawback to that model. However, there's definitely a drawback to doing that because it's unethical, it's illegal, and I don't know of anyone that actually wants to do that because you can really get bit back for doing so. Now, this is an insurance model, but if we take a look at how it would look in a from a patient to from a physician to a patient model, well, the patient is not just going to pay whatever the doctor uh, bills out. There's going to be a negotiating process um, before the doctor starts the treatment. The doctor's going to disclose what needs to be done, and then they'll probably negotiate a price, and or they'll go to get second opinions. And this is how the free enterprise system would control for costs and through competition reduce the price or the cost of healthcare. Now, there are different models and there are different arguments that can be posed for this, but this is in basic terms what happens. So capitation is a different model, and it's interesting because it puts forth a different incentive. So capitation is, let's say a physician has a certain amount of an insurance provider's patient. So let's say Blue Cross Blue Shield. This doctor's office has 100 patients that have Blue Cross Blue Shield as their insurance provider. Well, Blue Cross Blue Shield will go to the doctor or vice versa, and they'll say something along the lines of, "Hey, you have 100 of our patients. How about we pay you a salary kind of per patient?" And you just make sure that you take care of them whenever they need care and just keep them healthy out of the hospital. So this is a different kind of incentive model from the fee for service, and it's negotiated by the insurance and the doctors. Now, all of this is happening while there is very strict regulatory bodies being intrusive at every angle. And so it sounds, if it were that simple, for it to be very easy to be a smart system. However, it gets impacted in a negative way by so many regulations that are input in there, which we're not going to cover now, but it's an interesting thing to look into when you look at the reimbursement models for doctors. And managed care is something like HMOs, where let's say like a group of doctors or an insurance company mandates or says that there's a limited these are the doctors that you are set to see, and you can't go outside or we won't pay for them. So there are drawbacks, there are pros and cons to each of these kinds of reimbursement models, both for the physician and the patients, because let's say, for example, in the case for fee for service, you'd be able to go toward the best quality and choose your provider, whereas in HMO, you wouldn't be able to choose your provider. Is chosen for you, and the doctors here know that they have guaranteed care, or guaranteed reimbursement to a certain degree, so they will likely just, there's an incentive to do less for the same. And in this model, it's an interesting incentive model where it's being negotiated between mostly the insurance company and the physician. And the patient is just, I guess, a passive participant in it. And so it's kind of a passive participant. And what I mean by that is that the patient is not participating in the act of negotiating the price. They know that they're being covered by their insurance and that their doctor will cover for them. So they will just pretty much do as they're told and whatever, and go to whatever's free. And if a similar thing happens here in the managed care. So part of what's happening is that in the integrative sector, talking about, for example, acupuncture, through some of these systems, they're not covered. So acupuncture, for example, in the ACA, many of the insurance providers that were that emerged from the ACA did not cover acupuncture. So what happened with a lot of the patients were that they wanted a specific kind of care, but because they had managed care kind of service, they couldn't get acupuncture, and they would go to the ones that they would go they would they would receive the services that were covered for them. They would receive the services that were free. They were not going to pay out of pocket after they were already paying for a service that was mandated for them to pay. So there's a lot of different conflicting challenges that have to be taken into account there. And one would say, oh, it's as easy as including acupuncture into the ACA models or insurance, or mandating that they cover acupuncture. But there's a lot of drawbacks that are the maybe intended or unintended consequences that can arise from it. Now we have to take a twofold development for this conversation, being that we're not in a completely unfettered market, and that we can develop the conversation through a hypothetical model. And let's say that in an unfettered market of competition, this is what a model would unfold like, or this is what we expect and estimate that it would unfold like. And in the current system, this is what it's unfolding like. So this is what we're seeing, and these are some of the potential causes and correlations that that are tied to the consequences that we're seeing now, which are rising healthcare costs, meaning the price of attaining medical care and services is extremely high. And the reasons to that are very likely policies and flawed systems in place at the moment. So we have to revisit it from the fundamental aspect. Also look at the nuanced and specific details of how this unfolding is happening, and what are the different options. So let's break down again fee-for-service, capitation, and managed care within the context of mandating that the services that we're deeming, let's say, vital for improving healthcare and that we've deemed worthy of including are should be mandated to be covered. Now, I'm not of that opinion, but it's a widely circulating opinion. So I think that it's worth considering the consequences of and discussing them. So in the current model, let's say ACA, for example, several insurance policies emerged. Many of those insurance companies, as well as Medicaid and Medicare, as of right now, do not cover services like acupuncture and integrative therapies. So what ends up happening is that the patients, although they want these services and some are paying out of pocket, they tend not to go out and even after reaching out to find out pricing, they tend not to actually go forward with the treatment, because obviously they're going to go for what they consider free, right? Or what they've already have paid for. So within that kind of conversation, it easily transforms into, let's say, a field such as, let's say, my colleagues and my field, acupuncture, coming in and saying, well, you know what, let's speak to CMS, which is the Center for Medicaid Research, or I forget exactly what Center for Medicaid Medicare Services, something like that. And what they do is they analyze and assess the structure of Medicaid, Medicare, and see what services should or should not be covered and how the system can improve. And so there's been white papers or statements sent from the field to suggest that acupuncture and these services should be covered under under these federally or government aided and publicly funded systems, so that they can be made available to the public. And so acupuncture would then be covered by Medicaid, Medicare, and the ACA kinds of insurances through mandate. So I think that there's a conflicting, dissonant processing for this, because I think that yes, it's well intentioned and it's great, and obviously I'm partly biased in this because I would benefit from these services being mandated, and then obviously me having access to a greater population, and obviously even greater importance, a greater patient population has access to a service that would benefit them and have less side effects. So all of this is great. However, we do have to take into consideration, again, fundamental questions. Is this the way that we want to encourage, promote, and provide access to these services? And so that's where I differ in opinion, and I don't think that this is the model that I want to be engaged with. As a matter of fact, more and more, the whole goal of how I've been developing my business in particular is that I try to be independent of these systems. And the reason being is because of my relationships with MDs and DOs, and all of the interactions that I've seen, and as well my interaction and dynamics with the insurance model system, with the governmental systems, and the different bureaucratic processes of the VA and the Medicaid, Medicare, HMOs, patient-centered medical homes. All of my experiences with these kinds of models have led me to recognize that it probably would not be in the best interest for our field, for any field for that matter, or even for the patients, to have these services mandated. Rather, it would probably be better if these services were supported and stayed fruitful and alive and were accessible to patients, because there was such a high demand that supply would naturally emerge. So let me explain why this is, or why my opinion is biased in that direction. What I noticed, and this is actually verifiable, you can find that there's what they call a shortage of physicians, right? Of primary or family physicians. You can also find many criticisms of the Medicaid, Medicare system, because there is considered to be poor quality, and still lack of access, or lack of accommodability, or accommodation rather. And many doctors are also disenfranchised, or just really not intrigued by the Medicare, Medicaid system. So they're not willing to be in network, or get in panel, or start, or being in contract and taking and accepting Medicaid, Medicare patients. So this actually sets up for a very dangerous situation, because you have guaranteed care for which pretty much the US, everyone, all citizenry is paying for, giving everyone a little card that says, okay, you have coverage by Medicare, Medicaid. But most of the doctors that are in your area don't want anything to do with Medicaid, Medicare. And the reason why is that, well, it pays very little, right? So a doctor would have, and I say this from experience. So I've shadowed, worked with, I have many friends, established many relationships, and have this kind of interaction and conversation on a regular basis. Doctors have gone out of business because they're unable to keep up with the administrative costs, to keep up with all the bureaucracy of having to bill for and just account for all of the processes that you have to keep account for in billing Medicaid, Medicare, and charting, and all of these kinds of mandates and regulations that come with signing to a contract like that, while you're getting paid well under what would be feasible to sustain a business, a profitable business. I get that, it seems immoral or kind of unethical to think that a doctor would be practicing for profit, but it's a business. And so I think that if we were to revisit a value proposition for health, for medicine, and what it really costs, what people really value it, we would revisit these fundamental questions of should we have these kinds of systems mandated or regulated. So it happens a lot that doctors either go out of business or just decide to, out of the gate, to not accept Medicaid, Medicare, because they see that it will be unsustainable for their business. And also, I spoke about it earlier about it seems like a very virtuous notion to not be a medical practitioner that's for profit, and it seems kind of cruel to do so. But when I spoke about the personal conversation that I had with my son, you can see that it unfolds into a very interesting conversation, because how do you then interact with the current economic model, and are you then wanting to how are you going to incentivize people to innovate and become very adept at a very complicated, complex science and art? It takes quite an effort to become adept at it. So we have to take these things into consideration. And so what we were going to move on to now is how these regulations begin to impact even the private sector. So there's often talk about how free enterprise, free market, or capitalist systems wouldn't work for healthcare in particular, or in the medical field. And I completely comprehend the cautions and concerns with all of that. There are definitely well-cited market failures that we need to account for, that we need to take into consideration when we account for externalities. However, I don't know of a case where within the medical field or healthcare services sector, the free enterprise would fail in being able to provide a specific service, meet a specific demand, or supply the products and services that are needed to a specific certain or particular population. So moving on from that, let's touch on the actual engagement, the animated reimbursement model. We've gone on this subject for a long time, but I think it's a slide that is worthy of dedicating that much time on it, because we focus so much on it from the conversation of the ACA. So when we talk about public health, when we talk about the failure of the US healthcare system, most of the conversation falls back and always simply falls on making sure that we're providing insurance for people. So we touched on the fundamental question of do we really need insurance? And I think I'd like to touch on that more from the perspective of Milton Friedman, as he touches on, well, we would need it mostly maybe for in terms of like car insurance, where you only have it as a PIP or just for certain emergencies, but you wouldn't guarantee or mandate that everyone have insurance for a regular visit or for just any kind of service. It would be for a very specifically subset kind of services. And even then, I think that there needs to be a even more nuance based, and just already there's too much regulation. Taking off some regulation, or maybe drawing back on the regulation and policy formation and making would be good, but to what degree, I don't know. And I think that is worthy of exploring different models. So let's look at how these policies impact the insurance market and even raise the costs as opposed to doing what they're trying to do. So for example, the ACA, when it was established through the administration of President or ex-President Obama, was promised to reduce the cost of healthcare, reduce premiums, and maybe even said that reduce deductibles, and quite the opposite has happened. And actually premiums have raised, deductibles have raised, and healthcare is actually even more out of reach. Even though there has been obvious advantages to the system in that there's been more access to the lower socioeconomic status population to get healthcare. So it's difficult. It's difficult for some people to understand that, even though that is a good thing, within the context of the whole conversation, that would still be provided under a different model without, most probably without the unintended consequences of guaranteeing that happens. So there are two different perspectives there, right? One, trying to make sure that it happens, meaning that we guarantee access to that care by mandate, and one that we're trusting that it's going to happen because of the unfolding of the market system. But that's it. Now I actually want to touch on the insurance models and how they get impacted. So there are many ways that the healthcare, the cost of healthcare is rising. And one of the primary ways is the fee for service. Now, what happens is there are many, there's a lot of fraudulent activity. There's a lot of, I would say, regulations. There's a lot of intrusion, and there's a lot of natural development that happens in the insurance sector that rises the cost of healthcare. So I'll give you a few examples. If we now have, for example, guaranteed access, so the ACA is now sort of a publicly funded and managed system. So these insurance policies are guaranteed payment through the federal system, and so they have also guaranteed population that they're covering. These companies are essentially taking potential clients and customers from the market that would potentially buy private insurance, and so it leaves a smaller market for the private insurance sector to compete to get business from. So obviously, to compensate for a smaller population, they have to increase their fees to ensure that they're going to have the money to cover the administrative costs and cover the expenses for the activity of the risk pool. So whenever someone from that risk pool actually needs the care, it needs to get paid for, and so they need to have had the funds collected to pay for those. And so you have kind of like a vicious cycle there, where there's a continuing of increased cost. Then you also have the notion that patients get frustrated with having to pay high deductibles and high copays on the private sector when they already paying. So I'll give you an example. A patient may be paying, let's say, $300 a month for their health insurance through their employer, mind you. And so they feel that they're covered, yet when they go out and want to get a particular service, now this is through the private sector, so they yes, it's through their employer, but their employer contracted with a private company, right? So they're insured, and they're paying probably a high premium, what can be considered a pretty high premium, and presumably for a platinum or gold, or really good, or rather kind of coverage. However, when they go and they find that when they go and they seek the service that they want, they find that maybe there is no provider that's in network, and so they have to go out of network. So they maybe have to pay out of pocket, or let's say that their insurance, since they pay such a high premium, covers even out of network providers. Well, that's great, but they also have a deductible which they have to pay toward. So they have to pay the provider until that deductible is met, at which point the insurance will start paying for their medical services. Now, what happens is that the patient is only experiencing what they feel is excess amounts of payment and fees being paid toward their healthcare. So they don't want to have to then pay more elsewhere. So when they visit the doctor then has to negotiate not with them but with the insurance company. And you can see that there's sort of kind of like an unequal leverage there. But anyways, we'll go beyond that. And so what happens in that case is that the doctor then has a fee schedule, and they say, okay, this is the amount that we charge, and they send the bill to the insurance company, and the insurance company says, okay, hey, we're going to pay you this much. This is after the patient has already paid the insurance company, after they've already met the deductible, and after the patient has paid their copay, right? And so the insurance company says, yeah, you've billed us this much, but this is how much we are going to allow. This is our allowable. This is actually how much we're going to pay you. So they go ahead and they pay the provider this amount. So the provider gets the reimbursement for their services and say, hey, this is not what I billed you. And so what happens is that the provider then decides to say, well, if you're not going to pay me that much, then I'm going to have to increase my cost because my fees, or I'm going to have to increase my fees because the way that my schedule was set up is to be able to make sure that whatever I'm charging is going to provide to keep up with the administrative costs and all the costs basically of running the business, and be able to obviously profit to take home some money and enjoy with the family. So in order to do this, the provider says, well, if you're going to pay me less than what I'm billing you, then I'm going to have to charge more. And as this goes up, they are obviously setting up fees to match the insurance payment. But let's say then a consumer who is not insured comes and tries to receive medical care from this same provider and says, hey, I'm going to pay you cash, no worries. And so the doctor has already changed their prices to meet these higher costs, basically because they're having to deal with a discounted or kind of like an allowable from the insurance that's reimbursing them for their services. So they're going to present the patient with like, okay, these are my rates, but the patient is expecting to pay the full rate. They're not the insurance company. And so they're not going to go back to the doctor and say, okay, this is what you're telling me I'm going to pay you, but this is actually what I'm going to pay you. And as a matter of fact, actually, some patients will do that, right? And doctors are actually happy and would want to negotiate that with them and say, okay, you know what, you're a great negotiator and I want your business and I want to provide you service and you look like a kind person and it'd be great to go through this transaction with you. Yet providers don't do that. And the reason they don't do that is because it'd be fraudulent. So if they were to charge that patient a lower amount than they do the insurance, then for the same service, then they would have to charge the insurance company a lower amount, and then the insurance company would pay them a lower amount, even than what is they're charging. Obviously, I explained the allowable amount. So all of this kind of just back and forth through the system impacts the rise of healthcare. And obviously the rise of healthcare at the same time is additionally rising because the population that is demanding these services is growing shorter, or is shrinking rather, because there are mandated and publicly funded companies that guarantee services for very low amounts, which they're unsustainable business models. And so you have a private sector which is trying to be a profit making business, trying to compete with a business that doesn't really care about administrative costs or going at a loss because they're going to be funded anyways. So these are the very complex problems that occur in trying to regulate and place mandate and create policies to provide access to our So we touched on basically the definitions of health and noting that there are some gaps from what we define the concept of health as and what the clinical practice or what it looks like in the clinic, what it looks like in the field, what it looks like to patients when we're practicing medicine with them or on them. And what the treatments are stemmed from. There's a gap between the definition of health and how it's practiced, how medicine is practiced. There's also we also presented this or wanted to share and bring awareness to the fact that the concept of health is actually still evolving. We're still finding out that we actually were short-sighted. We were looking at it through a very narrow lens as to what actually health is. And so this is very pivotal. This is very important in negotiating policy, because dependent on what health means based on research, based on evidence, based on the evolving science, we would obviously focus our efforts in how we would structure mandate policy and reform to impact the health of individuals in our community. So we have to ask ourselves these fundamental questions in taking these concepts into consideration. Additionally, we then kind of navigated over to what integrative medicine offers, what the theories have inherent within them that make them a viable proposition, or at least their theoretical platforms have very the things that they can offer to enhance and augment our current allopathic biomedical system. We appreciated that our current medical system, our current healthcare system, stems post-Enlightenment era, which is emergent from a reductionist and materialist point of view, which allowed us to pierce with the scientific method through many dimensions to unravel some of the mysteries of genetic sequencing and finding predisposition for disease, and learning about embryological development, and all of these, basically labeling at the very microcosmic and microscopic levels. So we appreciated that dimension and that perspective of medicine, while recognizing that we actually can still improve the way that we practice medicine, the way that we approach healthcare, by reintroducing a phenomenological way of viewing things, a more appreciating that the subjective is actually highly valuable, and that the patient-physician relationship gets reignited when we take these more integrative approaches. We then continued on and explored the different ways or the different systems that are in place throughout the world to implement healthcare systems, or to create policy so that their people and their public are healthy and are being promoted their best and longest life, preventing disease. And we actually then critique the U.S. healthcare system for being so costly and being so expensive, yet seemingly providing low quality care and not meeting the standards that other countries that are developed and spending less money are doing. We also critiqued the research that is showing this. So we acknowledge that there are different variables that need to be controlled before we can compare other countries' healthcare systems to ours. There is a heterogeneous population here as opposed to more homogeneous populations in other countries. There's also the size of the population, which would make ratios and the proportionate statistics be a little bit more irrelevant in terms of comparing their healthcare systems to ours and their outcomes to ours. However, we still obviously take at face value that we do want to reduce the leading causes of death, because they're preventable diseases, and at the other end, they're also unintended injuries. So these are things that, despite what we may think of in terms of the weaknesses or the lackings of certain research in terms of measuring the quality of our healthcare system, we can still acknowledge that there are things that we should and can work on, like the preventable diseases that are the leading causes of death in the US. And we took that and said, well, these are the ways that we can do it. And we presented some of the integrative therapies, such as acupuncture, and how they're being implemented at the time, at this very moment. We also looked critically at the healthcare systems and reviewed the inefficiencies of policy that intrude in the natural development of the markets in terms of providing services that are demanded through the market system, and thus providing the public with the services that they want and need through a naturally emergent process. We then came back and assessed the whole situation from an integrative lens, and sought out opportunities and possibilities. We reflected on the possibility that there can be a private public health sector, that there can be efforts from the private sector that are going to be, or could be, very worthwhile and very promising and provide quality outcomes. We observe that there are possibilities for charitable services to emerge from the market system as well, should there be profitable businesses enough, so much so that they're able and willing to provide these services. We then moved on and appreciated that various different integrative therapies have different approaches to offer at a broader scale, such as urban acupuncture from the standpoint of geomancy, when you look at the Neijing and how they structured their cities, and how different development engineering techniques are being conducted in other countries and other populations. So from that perspective, we can appreciate that the complex adaptive system approach is being appreciated and put into practice, and it's a pragmatic way of implementing policy to impact healthcare system, or the public health and the outcomes. We also focused on the externalities, so some of the things that the market system is not being controlled for, and where there are perhaps apparent market failures with some of the contaminated, externalities, such as pollution and Wi-Fi pollution, light pollution, water pollution, air pollution, and so on and so forth. We then, I also briefly mentioned breath awareness campaign as a valuable proposition, which can be widely agreed upon. There is probably I don't know if there's any controversy as to the importance of breathing and the effect that it can have on health. So this would be obviously a very negotiable policy to support and advocate for. And we concluded with the very complex and complicated phenomena of insurance billing, the reimbursement models for current medical care in the United States, and how that implicates, or how that impacts and affects the rise of cost for healthcare and medicine. And pretty much that's been the lecture. We obviously went into more detail, and I had a few of my personal rants, but in synthesis, this is pretty much what we spoke about. And we went at every level. We would touch back at the fundamental, like recapping on fundamental questions as we were on very specific and detailed subjects, tying it back to our central subject of public health, while keeping the integrity of these fundamental questions that we need to ask all throughout the conversation, to keep a cohesive and coherent train of thought, so that we're not so that it's congruent, so that we're not providing contradicting opinions and ideas. So obviously this lecture was to engage in a nuance-based kind of uh, consideration for negotiating reform in the U.S. healthcare system, and hopefully also to invite others to do the same. So in conclusion, I want to ask you guys to reflect on these fundamental questions when you begin to consider the conversation of the U.S. healthcare public policy and the healthcare system and medicine. Do we really know, and how are you applying, and what are your answers to these very fundamental questions as we consider reform and policy? So things like, how do you define public health, and how do you define each of the terms within that term? How do you define public, and how do you define health? And is that congruent with how the system defines it? And if not, then what is the chasm that's happening there, and how would you reconcile with the two? Whose responsibility is public health, and whose responsibility is individual health? I think those may seem like common sense questions, but they're very impactful in the context of constitutional perspectives, meaning that we're creating policy that's going to impact our nation's laws. Also, you want to know what matters are of utmost importance, meaning if we're going to be trying to impact the healthcare system so that we improve the health of the public, is making sure that everyone is insured of utmost importance? Or should we be touching on more fundamental concepts of prevention and reforming at the fundamental level what public health means, what health means, and how we approach it, what strategies we're utilizing to attack this problem, and also how to attack the fundamental problems of the rise of the cost of healthcare. So how do we tackle the problems of administrative costs? Is the bureaucracy that is a natural emergence from government and public funded systems something that we have to reconcile with, or can we allow these systems to fail and engage in the free enterprise system so that better systems can emerge? And if we're going to do that, how do we control or create safety nets for the market failures and the people who become dispossessed and disenfranchised with that system? And what are the trade-offs? So as we begin to embrace and propose certain reforms, what are we trading it for? So if you're for more government, are you okay with mandating something and taking away someone else's freedom and liberties? What are the moral and ethical implications of all of these policies? Or if you're going to start defunding and deregulating, what are the implications and consequences, intended or unintended, of that? And do you have a general policy that you think is would fare off better? And if so, how would it do so, and why? I also do recommend you guys go check out, there's various tools on how to create your own budget for how the US spends its tax-paying dollars. So go and have fun with it and see if you can structure a deal or a system where we would be better off. So thank you for you guys joining me. Here is the list of references. There are probably more during my lecture. I actually gave out the actual articles, some, not all of them, but some of them. And if you guys have questions, contact me and we can share those articles with you. Thank you guys. Have a great one.